looking forward to Professor Sarah's talk. Thank you.
Thank you for that kind introduction, and I can assure you it was not written by me. Good morning, everyone, to a cold morning. For Velo standards, it's definitely cold. I'd like to thank the organizers at the outset, Professor Nihal Thomas and Professor Felix, for giving me an opportunity to present my data at this meeting. Over the next 20 minutes, after a brief introduction and a very brief couple of slides on the association between low birth weight and adult diseases, because it's very well documented now, I'd move on to the study on survivors, adult survivors of prematurity and their offspring, data from Auckland. After Professor Walker's hypothesis, we all know now that the environmental events during critical periods of fetal and early childhood can cause permanent metabolic alterations. And the link between intrauterine adversity and an increased risk of later diseases has been shown to be reduced insulin sensitivity. As we all know, insulin sensitivity is the ability of insulin to stimulate glucose uptake in tissues and suppress endogenous glucose production. And the single most important environmental factor amplifying the adverse effects of reduced insulin sensitivity is increased adiposity, in particular visceral adiposity. This slide very clearly demonstrates the long-term risks of insulin resistance. There was a group of 208 healthy adults and followed up for 4 to 11 years. Based on insulin suppression tests, the steady state plasma glucose was attained, and higher SSPG is equivalent to increased insulin resistance. And they looked at clinical events like hypertension, cancer, coronary heart disease, type 2 diabetes, and cerebrovascular accident over the follow-up period. And they noted that of the 40 clinical events which occurred during the follow-up period, 28 happened in those with the highest tertile of insulin resistance, 12 in those in the intermediate group of insulin resistance, and none in the group with the least insulin resistant. That means they were the most insulin sensitive. This very clearly demonstrates that there is a risk of increased insulin resistance. Are there metabolic similarities between children born low birth weight and those born at preterm? We know that maximum fetal growth occurs in the 3rd trimester. So a major component of the adverse intrauterine event can happen during the 3rd trimester. So like those born SGA, children born preterm also suffer from 3rd trimester malnutrition. Therefore, it is conceivable that those born preterm also show evidence of metabolic programming. Paul Hoffman's group from Liggins Institute demonstrated this in 2004. On the x-axis in health, these are healthy preterm prepubertal children. And on the x-axis, we have the preterm SGA and the AGA groups compared to the term AGA controls, term healthy controls. The white bar actually represents data from another study just for comparison in term SGA group. As we can see here, compared to the healthy term controls, those who were born premature had marked reduction in insulin sensitivity. And between the groups, within the prematurity group, between the SGA and the AGA, there was no difference, clearly indicating an independent effect of prematurity on insulin sensitivity. And this degree of insulin sensitivity reduction was similar in magnitude to previously shown data on term-born SGA children. So in prematurity definitely is an independent factor affecting insulin sensitivity. Subsequently, in an older Finnish cohort, aged between 18 to 27 years, using oral glucose tolerance test, similar findings were demonstrated. Those born premature had higher fasting insulin, higher 2-hour insulin, and increased home-IR insulin resistance. Similar data has come from other groups as well. But the data on body composition has been contrasting. There are, with using sophisticated measures like MRI, they have shown increased visceral fat in preterm babies at their corrected gestational age. But in childhood, lower fat mass and fat-free mass has been reported in preterm survivors. All these data have been on those born very preterm, that is less than 32 weeks of gestation. So there were very many unanswered questions. We know that the vast majority of the preterm survivors are those born between 33, just moderately or mildly preterm, 33 to less than 37 weeks, and whether these effects persist into mid-adulthood, because we know that the risk of adult diseases related to insulin resistance is higher as the age advances. More importantly, is the beta cell function affected? Do they have any impairment in insulin secretion? Is there alteration in body composition? Are they at increased risk for hypertension? And whether this phenotype caused by the environmental cues, whether it's heritable, whether any of these are passed on to the next generation. So we embarked upon the study on preterm adults and their offspring at the Liggins Institute, University of Auckland. We had a very interesting cohort. Between 1969 to 1974, the world's first ever Auckland steroid trial happened, where women with threatened premature labor were randomized to receive either betamethasone or placebo. Subsequently, looking at the data, this has become the standard of practice all over the world, and it has saved millions of premature children from significant morbidity and mortality. A subset of the offspring of this group was followed up by Stuart Dalziel et al. In between 2002 and 2003 in the Auckland steroid trial follow-up. From among them, we looked at those with children aged 5 to 10 years, and we recruited our cohort. So our study cohort had 52 adults aged between 33 to 38 years. They could be born either preterm or term, all were singleton, and steroid or placebo exposed, and they are all healthy. And 44 of these adults agreed for the children's participation, and 61 children were recruited. All the children were born at term. They were from a singleton pregnancy, they were healthy and prepubertal. The outcomes measured were on glucose metabolism, body composition, and blood pressure. In adults, we did hyperglycemic clamp study, which is a gold standard for assessing insulin secretion by the beta cells. And children had frequently sampled intravenous glucose tolerance test, and data was analyzed using Bergman's minimal model. Body composition was measured using DIXA. Both children and adults had their 24-hour ambulatory blood pressure monitoring done. We had a detailed questionnaire on diet and activity, and their oxological parameters were measured. Coming to the baseline characteristics of the adults who participated, as we can see here, the only difference was in the gestational age, with a mean gestational age of 33.3 weeks in the preterm group. In no other parameter, the group was different. Similarly, the baseline characteristic of the offspring group were similar in all aspects. Looking at the glucose metabolism in the adult data, on the left-hand side, we have the insulin sensitivity graph, and on the right-hand side, insulin secretion. Insulin sensitivity as measured by the clamp insulin sensitivity. The red represents the preterm group, and the blue represents the term group. So looking at the insulin sensitivity, we can see that the preterm group had a marked and significant reduction of insulin sensitivity as those compared with the term. And to compensate for this, they had increased insulin secretion. Therefore, the fasting glucose was similar between the preterm and the term groups. They also had a similar disposition index, indirect measure of actually measuring the ability of pancreas to compensate for reduced insulin sensitivity. Moving on to the children's data, on the left-hand side is the insulin sensitivity, and the right-hand side is insulin secretion. We can see that the children born of preterm parents had similar insulin sensitivity and secretion as those compared to the offspring of term parents. The body composition data was intriguing. The gray represents the preterm group, the black represents the term group, and there was definitely a sexual dimorphism in these parameters. There was no difference in height in either the men or women as compared to the term-born group. We can see the weight on the left-hand side, the y-axis, and BMI on the right y-axis. As we see here, in the preterm-born women, there was no difference in either the weight or BMI between those born at term. Compared to the men, the preterm men were significantly heavier and had higher BMI. And the preterm group had a higher percentage of obesity, leptin level, higher total cholesterol to HDL cholesterol level, and a lower HDL cholesterol level. Looking at the DEXA parameters, once again there were gender-specific changes. Compared to the term born, the preterm had increased total and truncal fat, as well as increased android-gynoid ratio. And when we reanalyzed, we found that the insulin sensitivity also is lower as compared to men born term. In contrast, the women who were born preterm had attained a similar height, The insulin sensitivity as compared to the term-born women was the p-value reached only 0.06, and they also had similar fat distribution. Coming to the body composition in the children, these are all term-born children, and we see that just like their preterm-born parents, the offspring of children born to preterm parents also had increased truncal fat and android fat to gynoid fat ratio. In all the other parameters, they were similar. Moving on to the blood pressure data. In the adults, we know that the 24-hour ambulatory blood pressure gives a much better blood pressure profile over the 24 hours away from the clinical setting and in their own during their daily activities. So we notice here that those born preterm, the adults born preterm, had increased daytime and nocturnal diastolic blood pressure. They also had mean 24-hour arterial pressure higher. And they also had an increased BP load. The blood pressure load is the number of times the blood pressure exceeds the recommended threshold. And they had a much higher, significantly higher BP load as compared to those born at term. In the data from children, only 26 of the offspring of preterm parents and 11 from the term parents participated. And compared to the offspring of term parents, there were subtle changes like a higher mean heart rate and daytime diastolic blood pressure in those born to children of the children of preterm born parents. We then looked at the cardiometabolic risk Z-score. So the clustering of the cardiovascular and metabolic risk factors is supposed to be a much better predictor for the long-term adverse outcome. So a sum of Z-scores of insulin sensitivity, total cholesterol to HDL cholesterol ratio, systolic blood pressure, and total body fat percentage were taken. 35 children who were matched for ethnicity were included. They were similar in age, birth weight, physical activity, caloric intake, and parental BMI. The only difference was, although all were born at term, the offspring of preterm parents were 0.5 weeks earlier, which reached significance. So as we see the graph, on the y-axis we have the clustered Z-score. The top graph shows that the clustered Z-score was higher in the offspring of those born to preterm parents. And when we analyzed further, that we found that this effect was more from mothers born preterm. So if you have children with your mothers born preterm, you have a higher clustered Z-score as compared to those born at term. Those born to preterm men were also higher, but it did not reach significance. Then we looked at the antenatal effect of antenatal steroid on the glucose regulation in adults and their children. In the adults, they had lower insulin sensitivity and higher insulin secretion, as has been demonstrated. But the same effects we have seen in children. Children born to the steroid-exposed grandparents, this is the F0 generation which is exposed to steroid, they had higher fasting glucose, fasting insulin, and higher indices of HOMA-IR. To conclude, preterm born, even those born at 33 to less than 37 weeks in their mid-adulthood have reduced insulin sensitivity of similar magnitude as term born. There was no impairment of insulin secretion. At least impairment in insulin secretion is not an early metabolic abnormality in those born preterm. There was increased adiposity, especially in males. There were blood pressure changes which were suggestive of a risk for later hypertension. And there was increased visceral adiposity and subtle BP changes in their children who were born at term. We speculate that prematurity is associated with at least two discrete yet interdependent programming effects, one on insulin sensitivity and the other on later obesity. We speculate that a programming in utero may have resulted in a permanent reduction in the number and function of skeletal muscle glucose transporters, this resulting in reduced insulin sensitivity. In addition to physical inactivity and dietary influences, there is a likelihood that in utero adipocyte programming may have predisposed them to altered adipocyte function and increased adiposity in later life. And the critical window for permanent alteration in insulin sensitivity seems likely to be the third trimester, possibly as an adaptation to the multiple adversities. The metabolic phenotype was accentuated in men. We don't have an explanation for this, whether it is a differential response to postnatal stressors between males or females, whether the males had a higher capacity to store fat and maintain the birth weight, which continued even postnatally, we are not sure. And the increased adiposity in the offspring of preterm parents, we speculate, may reflect transmission of an epigenetically modified phenotype from the preterm parent. There was also a differential contribution from maternal and paternal prematurity on the cardiovascular and metabolic risk factors, and we speculate that these stronger effects may be due to an interaction between heritable maternal factors and environmental influences. Like the low birth weight, preterm survival is also associated with later risk of type 2 diabetes, ischemic heart disease, and hypertension. But have things changed? We know that over the last 2 decades, there's so much of improvement in the management of prematurity, and probably the long-term endocrine and phenotypic profile may vary according to the decade they are born in. Because recent data have shown that survival has improved, there is improvements in ventilation, survivin therapy, the TPN is more optimized. We know that the protein content of the infant formula, the preterm formula, is also known to have associations with metabolic perturbations. So changes in all that has happened, and there is a publication demonstrating lesser insulin resistance. Yes, those who are born preterm have a reduced insulin sensitivity, but at a much lesser magnitude, about 25% as compared to 45% described earlier. This is an age group about 8 years of age and in very preterm, less than 32 weeks of gestation. So we do have to follow them up and see whether the long term there are effects or not. What is the public health impact? We know that gestation 33 to less than 37 constitute the vast majority of preterm births, and they represent the vast majority of the preterm survivors. Therefore, a substantial proportion of the healthy adult population are at risk for later sequelae of insulin resistance. Preventive strategies, we know that any in utero adversity affects the health of spring lifelong, so it is important to optimize fetal environment. Third trimester is easily accessible in the preterms. Manipulation of remedial factors such as optimal diet, etc., to minimize adverse programming and improvement of perinatal and neonatal care is very important. And most importantly, we know that the most important factor amplifying insulin resistance is adiposity. So early institution of lifestyle interventions, even from childhood, is important to prevent and delay the diseases. I'd like to thank all the participant families. They were very motivated and excited. It's a very laborious clamp models, frequent sampling, DEXA scan, 24-hour ambulatory, but the participants were very motivated. I'd like to thank my supervisors, Professor Paul Hoffman and Wayne Cudfield, who will remain my mentors lifetime, and my family who stood with me through this. As we answer questions in preterm, there are many more questions left unanswered. So I would like to stop with this quote: "Can you fathom the mysteries of God? Can you probe the limits of the Almighty?" Thank you.
She will present a talk on glucose metabolism in adult survivors of severe acute malnutrition. Dr. Debbie, you have the floor.
Thank you. Thank you for your words of introduction. And I'd like to thank the organizers of this conference for inviting me to share some of my work. I really look forward to sharing this with you. Okay. So we're going to talk a little bit about glucose metabolism in adult survivors of severe acute malnutrition. And this is work, the cohort that I've been following for about the last 10 or 15 years or so. So severe acute malnutrition, or as we call it, SAM, contributes to over 500,000 deaths per year worldwide in children who are less than 5 years old. Now, as the mortality from severe acute malnutrition declines as a result of better programming of food delivery and so on, there's a greater need for us to focus on the long-term health of SAM survivors, meaning now that we are more interested, or we instead of just thinking about children surviving, we're now focusing on children thriving and thriving into the future and into adult life. Now, there's limited data that suggests that those who survive might have an increased risk of cardiometabolic NCDs, such as type 2 diabetes and metabolic syndrome. But these mechanisms are not well understood or investigated. Now, SAM most commonly presents as one of two extreme clinical phenotypes: severe wasting, which in the old days we'd refer to as marasmus and still do, or nutritional edema, which was formerly referred to as kwashiorkor. These two phenotypes are known to have distinct clinical courses among children with SAM. Those with kwashiorkor typically have greater morbidity and mortality than those with marasmus. The origins of these distinct phenotypes are not clearly elucidated. We're really not sure why. It remains unclear why it is that children exposed to severe nutrient restriction develop one or the other of these phenotypes, especially since studies that have been conducted so far have not reported any reliable differences in their pre-morbid diets, any kind of environmental toxic exposure, patterns of infections, or genetic polymorphisms. However, kinetic studies conducted during hospitalization for SAM showed that while both phenotypes increase their protein and lipid turnover, as well as the salvage of urea and nitrogen to support energy metabolism and to maintain plasma glucose concentrations, we were able to demonstrate that infants with marasmus had higher rates of whole body protein turnover, higher rates of lipolysis, and greater salvage of urea and nitrogen. This suggests that these children with marasmus are perhaps better suited or better able to cope with the exposure to undernutrition that they experience postnatally. Now, there's a lot of data from animal studies, famine cohorts, and observational studies, which actually have established pretty much an association between prenatal undernutrition and type 2 diabetes. However, data from studies linking postnatal malnutrition and diabetes risk are only emerging and are few in number. So the question we wanted to ask in our research group is whether or not adult SAM survivors have an increased risk of glucose dysmetabolism than unexposed controls. What does the literature have to say about this? Well, we did find a few studies. So one study published in 2003 looked at the long-term effects of postnatal malnutrition in young Mexican men compared to controls. And it showed that malnutrition survivors had worse glucose tolerance and lower insulin sensitivity. And these findings were independent of birth weight, BMI, adult BMI, or age. And this is in comparison to a control group. So this provides some evidence that postnatal SAM may have some long-term effects on glucose metabolism. In a second study carried out by Pacific Mwene Batu in the DRC, he looked at 524 SAM survivors, median age 22 years old, and they were treated for SAM between 1988 and 2007. He also was able to assess 407 community unexposed age and sex matched subjects. And he again reported that SAM exposed participants had significantly higher HbA1c than the unexposed, but fasting glycemia was similar in the two groups. So in our own cohort of SAM survivors in Jamaica, we quantified serum metabolites using direct flow injection mass spectrometry. And when we compared the metabolomic profiles of these SAM survivors, we observed a partial separation of their metabolomic profiles based on the serum concentrations of selected metabolites. So what we did was what we call a targeted metabolomic analysis, where we pre-selected metabolites of interest. Now, these that are, and I hope this projects clearly, these that are identified here, these were the top distinguishing metabolite variables that were identified. So these were the ones that were quite distinctly different, significantly so, between SAM survivors and controls. And those enclosed in the black box below at the bottom are metabolites that were known to be associated with cardiometabolic risk, NCD risk. And when we look specifically at metabolites that were associated with the risk of type 2 diabetes, we show that SAM survivors, compared to match controls, had higher concentrations of the aromatic amino acids and the branched chain amino acids, which are known to be associated with diabetes risk in individuals with normal blood sugar. SAM survivors also had a higher KT ratio, that's a kynurenine tryptophan ratio, which is a predictor of incident type 2 diabetes and coronary events. The urea cycle amino acids were also higher in SAM survivors, and these are known to be associated with type 2 diabetes risk. Glutamic acid, which is associated with both increased 2-hour plasma glucose and higher tertiles of HOMA-IR, was also elevated in SAM survivors, as well as some groups of phosphatidylcholines, which are linked to increased risk of type 2 diabetes. So we are seeing some evidence in the metabolomic profiles of these SAM survivors that they may be at greater risk for type 2 diabetes. But bear in mind that a metabolomic profile is a snapshot in time, and it's not a dynamic test. So it does have limitations. Now, given the reported differences in the intermediary metabolism of children with marasmus and kwashiorkor that I mentioned earlier, we also asked the question whether survivors of marasmus and kwashiorkor could have distinct glucose metabolism after the episode of SAM. Again, reports from the literature are limited. Indeed, we managed to find a few. So Haddon et al. In 1967, as far back as then, reported that during the acute episode of SAM, children with marasmus had reduced plasma insulin, while children with kwashiorkor had normal to increased plasma insulin. James and Core in 1970 and Graham et al. In 1976 reported that children with marasmus have delayed glucose-stimulated responses up to 3 months after recovery from SAM, despite normal glucose utilization and lipolysis. Despite this, there are very few reports, if any, of studies investigating the differences in glucose metabolism in kwashiorkor and marasmus survivors as adults. So we had the opportunity to explore these relationships in the JAMACA study, which was carried out at the University of the West Indies in Kingston, Jamaica, where we retrospectively assembled a cohort of adults who were at the time aged between 18 to 45 years, and these were persons who were admitted to hospital with a diagnosis of SAM as children between the years 1963 to 1993. We also identified community participants who were matched on age, sex, and BMI, and a control group that was matched on sex and birth weight. The SAM survivors that are part of this cohort were all managed in hospital in accordance with WHO guidelines, and their diagnosis, as well as the classification regarding marasmus and kwashiorkor, was based on the Wellcome classification. Now, at the time of admission for SAM, we recorded the children's birth weights, which were based on maternal recall at the time of admission. We could do this, or we feel confident about this, because data from our own unit shows that there's about an 85% correlation with recalled birth weight and recorded birth weight at age up to 4 years. So from these recorded birth weights, we were able to determine that children with marasmus weighed about 300 grams less at birth than children with kwashiorkor. What does this mean? This finding, combined with the observed lower mortality of children with marasmus, suggests that they might have a survival advantage in keeping with the predictive adaptive response hypothesis. When we went on to evaluate the anthropometry and body composition of these SAM survivors as adults in the JAMACA study, we saw that the marasmus survivors were significantly shorter with a lower BMI, and the marasmus survivors are depicted in red in this plot. So they had a lower BMI, a lower fat-free mass, bone mass was lower, fat mass and percentage fat were also lower, and waist circumference was also smaller than the kwashiorkor survivors. And these relationships existed even after adjusting for age and sex and further adjusting for adult height. The survivors of marasmic kwashiorkor, which is an intermediate phenotype, had intermediate values between marasmus and kwashiorkor survivors as it relates to their anthropometry and their body composition. When we measured estimates of glucose metabolism using a 5-point OGTT, insulin secretion, as estimated by the insulinogenic index, IGI, was significantly reduced in marasmus survivors compared to kwashiorkor survivors and both control groups. However, insulin sensitivity, which is the whole body insulin sensitivity index, was not significantly lower in marasmus survivors and kwashiorkor survivors. It showed a tendency towards significance only. We also showed that marasmus survivors had an increased prevalence of glucose intolerance, about 19%, compared to kwashiorkor survivors, which were about 3%, and the control groups, which were 10 and 11%. In addition, marasmus survivors had higher concentrations of fasting insulin than kwashiorkor survivors. And these data suggest that poor nutrition in early life could cause beta cell dysfunction, which may in turn predispose to the development of diabetes. In a subset of 20 marasmus survivors, 20 kwashiorkor survivors, and 10 community controls who underwent hyperinsulinemic euglycemic clamps, there was no significant difference with respect to insulin sensitivity or insulin clearance. This again suggests that insulin resistance is unlikely to be a major contributor to glucose intolerance in marasmus survivors. These data suggest that the endocrine pancreas is plastic in early life. We concluded that children with marasmus may have experienced two nutritional insults, one during intrauterine life, hence the lower birth weight, and then another during the episode of SAM in infancy. It is not clear, however, if the defect in glucose-stimulated insulin secretion is due to reduced beta cell mass, altered beta cell function, or both. The other intriguing question arising from these findings is whether marasmus is an expression of atypical lean diabetes, which some of us have been engaged in discussing 2 days ago. Now, atypical lean diabetes has been described in persons with a low BMI and/or a history of childhood malnutrition. And in this cohort of Afro-Caribbean adult SAM survivors, marasmus survivors had a lower birth weight, they were more wasted and stunted at the time of hospitalization for SAM, and they remained thinner and shorter as adults compared to kwashiorkor survivors. These adult marasmus survivors, with their reduced beta cell function and little to no insulin resistance, are indeed similar to cases of atypical lean diabetes, reported in Jamaica, India, and Africa. So where do we go from here? Well, as part of our ongoing work, we are investigating mechanisms that could explain greater cardiometabolic risk in adult SAM survivors. So one of the things that we did in trying to get some mechanistic insights is that we used admission records to calculate the rates of weight gain during malnutrition treatment in these children. And we divided this weight gain into quintiles. We demonstrated a positive association between weight gain exceeding 13 grams per kilogram per day and adult waist circumference, fat mass, and android fat mass in regression models that adjusted for age, sex, and minimum weight for age Z scores. So what we saw here was essentially a threshold effect. When we compared quintile 5, which is the highest weight gain, to quintile 1, which is the lowest weight gain, we saw this association between weight gain and adult adiposity. Interestingly, because this that is presented here is a sex-aggregated plot, but when we disaggregated the sexes, we found that these changes were only significant and carried forward in males only and not in females. So that's another intriguing angle that we're investigating and writing up. We're also interested in investigating the metabolic flexibility in SAM survivors. And we recently concluded a study of the postprandial metabolome after mixed meal tolerance tests in malnutrition survivors, and again, their age, sex, and age and sex match community controls. And these samples are now being analyzed, and hopefully we'll be in a position to report on it soon. Finally, I'm pleased to report that our group has just received funding to measure markers of inflammation in these adult SAM survivors and their controls. We know that systemic or low-grade inflammation occurs during the episode of SAM. We also know that many of these cardiometabolic NCDs, in persons with cardiometabolic NCDs, there's also some element of low-grade inflammation. What we do not know is whether or not the low-grade inflammation that existed during SAM persists through the life course and is associated or it drives in any way cardiometabolic NCDs in adult SAM survivors. So in closing, we would like to make a few recommendations for future work. We suggest that more studies with clearly defined populations, which include marasmus versus kwashiorkor, or severe wasting versus edematous malnutrition, adequate sample sizes, considerations of the sexes separately, because we have come to realize that adjusting for sex and disaggregating data by sex can produce completely different results, and also combining them with robust current techniques. These studies will allow us to better determine the relative contributions of beta cell mass and function to insulin action in glucose intolerance in adult SAM survivors. I want to thank the participants who very bravely soldiered on through all the tests that we have done over time.
Thank you, Michael, for the kind meeting. This is my first time in Vellore, even though I've been to India before, so I'm quite excited to be here. Heard a lot about the place, and I've been working with Dr. Nihal for some years as well. So, in my section where I work, we are, one of the aspects we are looking at is the nexus or interaction between communicable and non-communicable diseases. Typically, that will be tuberculosis and diabetes, but also HIV and cardiometabolic diseases, both naive ART or ART-naive patients and those on ART. And then this study, or the area focus of today for me, will be on malaria and diabetes, which is a less studied area, whereas the two others are more, we know much more from those interactions. So when we look at malaria infection and compromised fetal growth and diabetes, well, we know that malaria causes anemia. That's quite known. And it's also quite known that anemia may cause low birth weight. And that low birth weight is a risk factor for cardiometabolic diseases, including diabetes. But what happens when malaria parasites sequester in the placenta? This may cause an increased clinical cardiometabolic risk, and that's what we set out to do, to see what if we could find some associations. And the picture, or you see there, is the placenta, which is infected by malaria parasites. So just an overview of a few studies out of many, many studies that have been done on the effect of placental infection of malaria and birth weight. And you can see clearly here that there is a substantial effect on birth weight if you do have placental malaria infection. And if it happens, what are the compromised functions that we see? Well, if the human placenta is infected, it may compromise nutrients to the fetus, and it may also compromise oxygen supply to the fetus. And this is important because if we look at developmental programming, we know that many environmental conditions will have an impact on the fetus. So this is a graphic overview that should be, or will be at least after this talk, and other talks later will be familiar to you. So could be anything from smoking to infections where malaria could come in, genetics, under overnutrition, and so on and so forth. But we also know that type 2 diabetes is a multiple organ disease. There will be more on this later today by Professor Lund. From this graph here is taken from one of his publications. So main organs are involved and affected by fetal programming. So I just quickly put this together in a graph to see what could be the difference between peripheral and peripheral plus placental malaria infection. So in your left-hand column, there will be peripheral, and in the right-hand column, it will be peripheral plus placenta. So both will cause or can cause anemia, but at the same time, there will be placental inflammation if the parasites sequester in the placenta. And both cause angiogenesis and fetal hypoxia. But if there is malaria infection in the placenta, there will also be uteroplacental artery blood flow resistance, which could make a difference to the amount of blood going to the placenta, going to the fetus. So if we look into the malarious areas, so how many pregnancies are affected? Well, we know that there are, or it's estimated there are about 100 million pregnancies globally in high endemic malarious areas. And about 25% of those will be affected by malaria. So it's quite substantial, the number of pregnancies that are affected and may have these consequences that I was talking about. So one organ, important organ for glucose metabolism is the skeletal muscle. So we were thinking that they could be affected by this malaria infection. And just to make sure that we are on the same page, and if you don't remember your physiology from skeletal muscle, just put together this slide here from the 3 different muscle fiber types that we have, humans have. Type 1, oxidative fibers. Type 2A, an intermediate fiber between oxidative and glycolytic fiber, and then type 2X, which is the typical glycolytic fiber. And the idea here is that that the skeletal muscle in the fetus may adapt to the environment if there is a state of hypoxia. So that low birth weight actually affects the skeletal muscle distribution was shown in an earlier study by a group mainly from the Steno Diabetes Center Copenhagen. And they did show that low birth weight was associated with an increased proportion of type 2X fibers, so the glycolytic fibers, at the expense of a decreased proportion of type 2A fibers. But it also showed that the mean area of type 1 and type 2A fibers was increased as, due to the adaptation. And the combined effect here was that this may reduce oxidative capacity and GLUT4 content from that study, going back almost 20 years. So apart from that study, we were also inspired by and looked into studies that have been done at high altitude. High altitude would be above 3,000 meters above sea level. And here, those born or the fetus is subjected to a so-called double insult of hypoxia, meaning that there will be lowered maternal arterial oxygen partial pressure and a decreased uterine blood flow, as I mentioned before. But we were set out to do a study on the coast of East Africa, which is not high altitude, so they were, at least in theory, only exposed to a decreased uterine blood flow. And again, looking at the tissue changes associated with exposure to hypoxia, so high altitude, and there are quite some important features here that you can see. Skeletal muscle, as I showed before, is being affected. Also, myoglobin concentration is increased in skeletal and heart muscle. Muscle enzymes will be changed also with an increase in glycolytic and a decrease in oxidative enzymes, and there will be a reduced density of mitochondria in order to adapt to the hypoxic environment in the fetal state. So all this added together, I've put here in a graphic way the Parker hypothesis, and then on top added hypoxia and maternal malarial infection, and then under fetal malnutrition, I've added hypoxia. So this will be an expanded, you could say, Parker hypothesis, now including malaria as an infection exposure. There was a group from Germany and Ghana that carried out a study in 15-year-old young girls, boys and girls, or teenagers who were exposed to malaria during pregnancy. The study was in about 150 women and their offspring, and it showed that those who were exposed to placenta malaria had an increased fasting blood glucose, increased fasting blood glucose levels compared to those who were not exposed. But when it comes to blood pressure, they couldn't show any difference. So we set out to do a study to expand on this and do more sophisticated measurements, and we went to the northeastern part of Tanzania on the coast, in the region of Tanga, and the study was carried out south of Tanga in a district hospital. And we had data from an old study done 20 years before on malaria prophylaxis. And the young men and women we studied were between 17 and 22 years of age. We were able to contact 101 out of about 330 children from this malaria in pregnancy cohort. And a total of 75 of those were eligible to participate in the study. And of these, we had, in 50 of these, we were able to do a skeletal muscle biopsy. And the reasons for not being eligible were a mix between pregnancy, HIV positive, hepatitis B, not showing up, and we also had one case of a mother who did not finish the original study, so we could not include the child. This is just an overview of the study setting. So you can see we did many different cycle tests for oxygen uptake. We did a clam test. We did muscle biopsy, ultrasound scanning for abdominal fat distribution, OTTT, blood pressure, Bayer for body composition, apart from the ultrasound scanning and others. And it was an euglycemic hyperinsulinemic clamp we did. Before we published a paper on the background where we argued that this could actually have an effect on the metabolic consequences if the offspring was exposed to placenta malaria. So the first paper we published on this came out a few years ago on the effect. And if we look at the background data here, you can, I've circled a couple of the results showing that malaria density in pregnancy was a little bit different, but not significantly, between those who had peripheral malaria and those who had peripheral and placental malaria. And when it came to birth weight, there seemed to be a tendency towards lower birth weight in the group with peripheral and placental malaria compared to the other two groups, but again, it did not reach statistical significance. But when it came to results from the oral glucose tolerance test, we could show that at 30 minutes there was a higher blood glucose level in the peripheral and placental malaria group compared to the two other groups. And there are two p-value columns here, and that's because the distribution of men and women in the two groups was not the same. So we had to adjust for the number of men and women in the two groups. But if we look at clinical conditions, and not the continuous variables, but those who had clinical conditions, results showed that there was one with diabetes, and that person was in the peripheral and placental malaria group. ITT we saw in all three groups, and IFG only in the peripheral and placental malaria group. When it came to hypertension, there were substantially more of those in the peripheral malaria group, and low C-peptide, which is below 300 picomolars. There were substantially more in the peripheral and placental malaria group. Whereas overweight was not really a significant problem, and none were found in the peripheral and placental malaria group. So the other paper from this study was on skeletal muscle, fiber type, and enzymatic activity. So we wanted to see, did it have an impact, the placental infection on skeletal muscle distribution? And the answer is no. There was absolutely no impact, neither on the skeletal muscle distribution nor on the enzyme activity, even after adjustment. So that indicates that it's not insulin, a lack of insulin sensitivity or insulin resistance that is a problem with malaria infection during pregnancy. But we did show in this sub-study of the 50 that there was, again, a higher blood glucose in the 30 minutes, even here in the fasting also, but also that this precision index was much lower in the peripheral and placental malaria group. Again, indicating that it's insulin secretion that is the problem rather than insulin resistance. So to conclude on the study, we saw no differences in birth weight, even though there was a tendency towards lower birth weight in the peripheral and placental malaria group. There was no impact on peripheral insulin sensitivity measured by the gold standard method, the CLAMP study. We saw subtle differences in insulin secretion in relation to insulin sensitivity. And we did not identify any cardiometabolic risk markers by in utero, placental, and peripheral malaria exposure between these two. So maybe we could add them and look at them as one group. That's a possibility. And these subtle elevated plasma glucose levels that I already mentioned were seen, and no difference in skeletal muscle fiber type or enzyme activity in the offspring was seen between the three groups. But it's also important to say that exposure time may have been too short to make a substantial metabolic impact, exposure time to malaria, and thereby hypoxia. And also the pregnant women were part of a malaria prophylaxis study, and this may have blunted possible adverse effects. So we are not seeing the real effects that may be out there in real life. It may also be that the sample sizes were too small, that the study was underpowered. We did not find the number that we wanted to. We wanted to have at least 20 in each group, and 2 of the groups that we had less than 20, and that was based on a power calculation on the M value. And then there's a need for larger and extended deep phenotyping studies in the future in order to find out if there is indeed a difference. Right now, not a difference, but if there is an impact of placental malaria infection. Right now we can't say for sure, but I don't think we can dismiss it either based on the study that we did here. So with these words, thank you for your attention.
For that fascinating talk, and I guess now is the time for the panel discussion. So I guess we can invite all 3 presenters to just to come forward as the audience starts to gather their questions together. So I'll just invite the other 2 presenters, and I think I see someone. Yes, so go ahead.
I'm Sri Nair. Very fascinating 3 talks. I think we can understand a lot about human adaptation to various environmental factors by these studies. Especially I'm fascinated by this post-SAM group of patients. If you can do needle biopsies of their adipocytes in the fat in the lower extremity and upper extremity, and look at the fat cell size and also fat numbers, that can give you a lot of information about the future development of obesity and the metabolic problem. Second is, again, I would say that needle biopsy of the muscle, looking at mitochondrial biology, especially mitochondrial DNA copy number, and also mitochondrial functions, mitochondrial efficiency, that also can get us a lot of information. Third, of course, you may be doing it already, but in terms of methylation of DNA, which also may give a lot of information, adaptation occurring during the malnutrition period, and its imprint on future metabolic problems. That's just a comment and a suggestion.
Thank you.
Good morning. Al Powers from Vanderbilt University. That was a very, very good session. All 3 of those talks were spectacular. So I'm just going to ask a question for Professor Simmons, if I could. I was intrigued by the difference in effect of malnutrition as different decades, right? So let me ask, and you don't have the specific data, but get you to speculate. If you had malnutrition in utero, but not post-birth, will that be a difference? And in Western societies, we have so many infants now who are born at very, very low birth weights, and so the neonatal intensive care units, and then after that, they catch up. So could you speculate on those different entities and what it might do to ultimate insulin sensitivity or diabetes risk? Thank you.
Okay. Thanks for the question. So to your first question about prenatal as opposed to postnatal undernutrition, well, I'm of the view that they both have effects. As long as they occur during that period of plasticity, they both will have some kind of effect. And these effects may in fact be additive. And that is part of the reason why we were interested in seeing and why we hypothesized that marasmus survivors, would have greater cardiometabolic risk because they would have experienced two insults, one intrauterine and one postnatally, and that those effects could be additive. So that is one perspective that we have on it. Can you say the second part of your question? I'm not sure I heard it clearly. Right, so again, the thinking is that children who start off very low birth weight or low weight, whether small for gestational age, low weight, and then catch up quickly, are at greater risk of cardiometabolic NCDs and greater adiposity as adults. So part of what I was showing was similar to that, where our malnourished children, of those who during nutritional rehabilitation gained weight faster, they had greater adiposity as adults. So I believe in the same way that children who are neonatal small size and who catch up should have greater risk as adults and greater adiposity.
Can I ask a question from here? This is Sarah Mathai. Thanks very much for that presentation, and I was really interested to see the steroid data coming through from the F0 generation right the way through to your children, your children. Given that the animal work shows, lots of groups have shown that HPA programming steroids have effects over several generations. I wondered if you'd done any HPA studies in the adults or the children offspring of actual HPA functions, stress testing, this sort of thing.
So we did have data on the cortisol levels, which I did not show. The cortisol levels in the offspring, in the children study, the offspring of preterm parents had actually higher 8 AM cortisol levels. So that would mean an affection of the HPA axis. Even the changes in the blood pressure were actually subtle, but combined with the fact that they already in the prepubertal age have increased adiposity, visceral adiposity, maybe this will, they will develop a metabolic phenotype later on. Only follow-up studies will actually be able to say. All the other parameters like leptin, adiponectin, we did a whole lot of hormones. All of them were normal except for elevated cortisol levels.
Dr. Debbie Thompson, in your cohort, do you find some iodine deficiency or hypothyroidism in this severe malnutrition?
What kind of deficiency did you say?
Do you find iodine?
Iodine, yes.
Iodine deficiency or hypothyroidism in this cohort?
We didn't look at that at all.
Okay.
Question from Gopal. So my question to Dr. Dirk Thompson on malaria and pregnancy. It was a really great presentation which was being made and did provide intricate details about this topic. I just had a question that was there a difference in the outcome found based on the species of malaria, like Plasmodium falciparum or vivax? So was there a difference in the outcome based on the malaria species?
No, that it was falciparum, all of it. Yes, so there was no difference. We could have looked into the different types of prophylaxis that they were given, but the study was too small to adjust for that. So, but it was all falciparum. Yes.
Thank you.
Okay. I just want to make a comment on a question, and Debbie, you have a question also. I have independent data for you, but that we don't have iodine deficiency in Jamaica. We recently completed a study where we couldn't find a single person with iodine deficiency because of the salts being iodinated. So that should not, we are assuming, be an issue for those individuals. And I'd also wanted to ask Dirk. Sickle cell disease is very common in our ethnicity, and I was wondering if, and it could also contribute, even though it might help to protect against malaria, but it might also contribute to fetal hypoxia during pregnancy. So, do you know if any of the women were even sickle cell trait positive, or had the disease itself, or their offspring?
No, we don't have data on that. Yeah, unfortunately, that would be, of course, very interesting, but there's no data. And it's important for me to add also that the baseline data from when the malaria study was, or prophylaxis study was done, was not meant to do a follow-up on what we did. So then we would have done a lot more. Yeah. Now we have a new study going on, but that will be some other time. Yeah.
Right. And I think Debbie, you had a question for Dirk.
Right, good. I do. So I wondered when I was listening to your presentation whether or not you had specific data on the timing of the malaria infection, and if you did or did not, whether you thought this would be significant in your findings as it relates to beta cell function as opposed to insulin sensitivity and so on, whether the timing of the infection would have a differential effect on those two outcomes.
That's likely, but we do have that. But again, the study is too small to see if it made a difference. But we have a new study where we can do a follow-up, and we have first, second, and third trimester. Here we only have second and third trimester, so we don't know what went on in the first trimester, unfortunately. Yeah.
Any other questions or comments? Doesn't look so. Well, maybe I might ask another one. Dirk, is it just your cohort is too young? You know, the average age of the cohort that you're following, the offspring, they were 20. I'm just wondering whether or not a longer-term follow-up might...
Yeah, we just published a 6-year follow-up. And not all of them are from offspring from malaria exposure. So there's a variety of the age, but it's a 6-year follow-up, but at different ages. Yeah, I'm not saying anything right now. I would like to be invited to another conference.
Yes. So I'm not seeing any more persons rushing to the mic at this stage. So if not, then I guess we could thank our speakers for a fascinating session. And best wishes with also the future work that you have in these very important areas. So let us thank the speakers.